طيب بسم الله. Assalamu alaikum. Hello everyone. My name is Ibrahim Aldakhil. I'm a fourth year medical student. Today I'm going to be giving you the cardiac cycle lecture, acute coronary syndrome, inshallah. I hope you guys are going to find it useful. Before we begin, I want to give you a brief overview of the lecture. And before anything else, I want to state the purpose of this lecture. Now, one could say, why should I watch this lengthy video? I don't know how many minutes it's going to be, but when I could just watch like a 10-minute online med video. So to try to make this video as useful as possible, I tried my best to incorporate multiple different resources and bring you guys some useful information that I learned even after third year. And I also want to go into the mechanisms a little bit more to sort of give you a holistic picture of why everything is the way that it is. So this lecture is going to be more on understanding rather than pure memorization. And I'm going to do my best to sort of hammer down the important points so that when you take the actual lecture in uni, it's going to be a breeze. So that's the purpose. And I've incorporated a bunch of resources here and there, online med, first aid, UWorld, Pathoma, the university's lecture, the teamwork 438's lecture, which was a great team, by the way, I highly recommend it. So I tried bringing bits of information from all of these and compile them here. Now, the outline of this lecture is that I'm going to be beginning with an anatomy refresh. Then I'm going to be going to an introduction to acute coronary syndrome, and I'm going to be talking about STEMI and NSTEMI, unstable angina, stable angina, all of that. Then we're going to go into the pathogenesis and risk factors of ACS, and we're going to go into the approach. Obviously now in third year, your studying is more clinical than basic, so it's really important to know how to approach a case from the signs and symptoms, investigations, all the way to the management. And we're going to be covering all of those, inshallah. Next, I'm going to finish off with complications. And yeah, let's begin. So, first of all, the anatomy and blood supply. This is the coronary blood supply of the heart. And it's really important to know the coronary arteries and which areas they supply in the heart. And I'm going to be explaining why in a little bit. First off, you don't need to know every single coronary artery listed here. There are a few important ones that I need you guys to know. And I'm going to be going through them right now. The important ones include things like the LAD, the left anterior descending artery, the LCX, the RCA, and the PDA. To me, those four arteries are the most important ones, and I'm going to be going into more details about those right now. First of all, some basic information about the coronary blood supply. Usually, the heart receives its blood supply during diastole. So the diastole or the relaxation point of the cardiac cycle is really crucial to the heart because this is the period where it extracts the oxygen and gets its blood supply. And fun fact, the coronary blood supply has the highest oxygen extraction in the entire body. So literally about 60% of the oxygen content in the blood is extracted immediately during diastole by the heart. And in terms of dominance, some of you may have or may have not heard about the dominant circulation of the heart. However, it's important to know the posterior descending artery's origin. Where does it come from? 85% of the time, the dominance is right-sided, meaning that the PDA will arise from the right coronary artery. Sometimes it can arise from the left side when it's a left dominant circulation. And in this case, it can arise from the left circumflex artery, or it can be co-dominant. But what I need you guys to know is that most of the time it's right dominant, and it's usually from the RCA, the posterior descending artery. Like, why is this important? Why should I know which coronary artery supplies which area in the heart? This is important for ECG localization of ST elevation myocardial infarction. It's really important because you can identify just by looking at the ECG where the ST segment was elevated, which artery was affected. And this is really important if you think about it. So just to give you a brief overview of what areas those arteries supply, the left anterior descending artery and its branches usually supply the anterior surface of the left ventricle and the anterior 2/3 of the interventricular septum. So if somebody has an infarct in the anterior surface of the heart, it's usually the LAD that's affected. When it comes to the PDA, the areas that are supplied by it include the AV node. And keep in mind that this depends on the dominance. So for example, if the PDA was from the RCA, that means the AV node's supply comes from the RCA. If the PDA was from the LCX, that means the AV node supply comes from the LCX. So it also supplies the posterior two-thirds of the ventricle, the posterior third of the interventricular septum, and the posterior medial papillary muscles. So notice that it's usually the posterior area of the heart. Also, the RCA, this was the PDA. Now going on to the RCA, it supplies the SA node, and this is independent of dominance. So that means regardless of the dominant circulation of that patient's heart, the SA node is always supplied by the RCA. And the RCA supplies the inferior surface of the heart, meaning that if somebody had a myocardial infarction in the inferior surface of the heart, you should immediately think of an RCA infarct. Okay, so let's go on to the localization now. And from the ECG image below, there are three most important things that I need you to take out of this image. First of all, if you see ST elevations in leads 2, 3, and AVF, this is an inferior wall myocardial infarction. And as I just mentioned, think of an RCA infarct. Now, here's a fun fact. It's just like side information, but the most common complication of an inferior wall MI is bradycardia. And the management of bradycardia is atropine. So if you recall how the cholinergic system works, you have the M2 receptors in the heart, and atropine is an anticholinergic. So normally agonizing the cholinergic receptor in the heart is going to slow down the heart. So atropine is going to oppose that effect, and therefore it's going to counteract the bradycardia. So just a basic information refresher. Next, we have leads 1 and AVL. For those, think of a lateral wall infarct, and the lateral side of the heart is usually supplied by the left circumflex artery. And V5 and V6 can also be implicated in anterolateral MIs. Okay, then we have V1 and V4, V1 through V4. This is anterior wall MI, and I mentioned previously that the anterior wall is supplied by the left anterior descending artery. And the left anterior descending artery is the most commonly occluded artery, and it's also the deadliest. It has the highest mortality rate. Okay, so now that I hope that you have a refresher, you've refreshed your information on the basic anatomy of the heart. Now you're able to localize the myocardial infarction based on the areas affected. So now we can go on to ACS. Now, what is ACS? Acute coronary syndrome. In very simple terms, it's a blockage in the coronary arteries caused by atherosclerosis. And I'm going to go in more detail about atherosclerosis in the next slide. But for now, I want you to realize that acute coronary syndrome is a spectrum. What does that mean? Well, let's take a look at that spectrum. So we have four main things that I want you to understand about, or four main diseases that I want you to understand in ACS. We have stable angina, unstable angina, NSTEMI, and STEMI. Each one is worse than the one before it. So that's why I said it's a spectrum. Beginning with the least severe one, stable angina, this usually has pain on exercise, exertional pain, and it's relieved by rest or by taking nitrates. There's no biomarker elevation, which by that I mean troponins and CKMB, cardiac enzymes. There's no ST changes in the ECG, and the degree of stenosis in the coronary artery is 70%. So when it becomes more severe over time, and the pain is occurring at rest, and it's not relieved by rest or by nitrates, you're entering the territory of unstable angina and NSTEMI. How can you differentiate between the two? Well, both of them have pain during rest. Both of them are not relieved by rest or nitrates. However, NSTEMI has elevated biomarkers. It has elevated cardiac enzymes. Notice that both of them have identical ECG changes. You'll have ST depression, sometimes also accompanied by T wave inversion. And the degree of stenosis is pretty much the same, around 90% for both of them. So really important to differentiate between the two, the biomarkers. Keep that in mind. Next, the most severe one is the classic MI that we know, which is STEMI, ST segment elevation myocardial infarction. In this case, yes, biomarkers are elevated. However, the ST changes are different than in STEMI. It's elevated rather than depressed. And really important to know that STEMI occurs when there is 100% stenosis or occlusion in the coronary artery. So the entire artery is blocked. This is when you have STEMI. All right, so moving on to atherosclerosis. And sorry, just one more thing I wanted to mention about this spectrum is that the first three, stable angina, unstable angina, and STEMI, these are all referred to as demand ischemia, meaning that the more you the more you work yourself, the more demand of oxygen you require, the more severe the symptoms will become. But once you reach 100% occlusion or thrombosis, in this case, this is STEMI. Okay, moving on to atherosclerosis. Generally, whenever anybody of us hears atherosclerosis, we all say, "Oh, yeah, we know that. It's the buildup of cholesterol." And usually, examiners know that you know that. So to really test you about your knowledge of atherosclerosis, they're going to go into a little bit more detail. They want to see if you really understand how atherosclerosis forms in the first place. What is its pathogenesis? Why does it occur? And how it develops over time. And this is what I'm going to be covering in this slide. I hope that you'll have a very good idea of how atherosclerosis forms. And let's begin by explaining what atherosclerosis is in the first place. So it's a cholesterol intimal plaque of medium to large sized arteries. This cholesterol plaque, by the way, intimal, I'm referring to the intimal layer. If you recall, the blood vessel has three layers, the tunica media, adventitia, and the intima. The intima is the innermost one. So you'll have cholesterol buildup in the intimal layer, and this plaque consists of a necrotic lipid core and a fibromuscular cap. So what is the pathogenesis of atherosclerosis? Why does it happen? The key word here is inflammation. And I'm going to be explaining the steps of why that happened. Okay. So if you get asked, what is the first step in atherosclerosis? Usually, it's endothelial damage. This is the trigger to atherosclerosis. When there's endothelial damage, fat, which is LDL, is going to leak inside the intimal layer. And this will be accompanied by accumulation of macrophages. So that's the first step. If that happens, what's next? Well, you're going to have the formation of what's called a fatty streak and foam cells. So the macrophages are going to phagocytose the LDL. And what happens is that you get foamy macrophages. Some of you might have heard that term before, or lipid-laden macrophages. It's basically macrophages phagocytosing the LDL. And by the way, atherosclerosis is a process that begins at birth. So the minute you are born, this process might already be undergoing. So in teenagers, a lot of teenagers actually already have fatty streaks. And fun fact, I had a question on one of the Q banks of USMLE. They gave you a teenager and they said they found this yellowish substance in his blood vessels, and they ask you what is the predominant cell type. So if you understand the pathogenesis of atherosclerosis, you would know that the answer was macrophages. So I want to hammer the point that even teenagers can have fatty streaks. It's not usually when we think of atherosclerosis, we think of old people, but it's a process that begins at birth and it slowly builds up over time. All right, so what's the third step? The third step is, I called it inflammation/healing. And notice that I put it in red because it's super, super, super important to know this concept. The smooth muscle cells in the tunica media are going to migrate into the intimal layer. This is a very important thing to know, okay? And this will lead to smooth muscle cell proliferation plus extracellular matrix deposition. So these are all key things that happen in inflammation. So that's why there's a process of inflammation/healing going on here. But always know and keep in mind that smooth muscle cells are going to migrate from the media layer to the intimal layer. Really important that you know that. All right, next. All of this happening together is going to eventually lead to the buildup of a fibrous plaque. And this fibrous plaque is going to narrow the lumen, which will eventually cause stenosis. And over time, this plaque can calcify. So this is basically, in a nutshell, atherosclerosis and the steps of its pathogenesis. Okay, so you can look at the diagram on the right to sort of understand or visualize how that happens. Notice at the bottom of the diagram, on the bottom right, there's a thrombus or an occlusive thrombus, and this is causing 100% occlusion, which, as I mentioned before, will lead to STEMI. Will lead to STEMI, ST elevation. So there are a few important points that I want to mention here before I move on to the next slide. If the fibromuscular cap ruptures, this can lead to an MI even if the stenosis was only 20%. So we mentioned before that usually STEMI has 100% stenosis. Yes, but if there's a plaque and it's stenosing only 20%, but the fibromuscular cap ruptures, this can trigger thrombosis. And I'm going to explain how that happens in the next slide. So what increases the risk of rupture? This is a common confusing point for a lot of students. It's a thin fibrous cap and a large lipid core. A large lipid core can make sense, yes, but some students often confuse between a thin and a thick fibrous cap, and sometimes you'll see in the choices of any exam, whether it's QBank or any exam, they can put thick fibrous cap in the choices to trick you. So keep in mind, it's a thin fibrous cap that increases the risk of rupture. And I actually had this very point tested in New World, one of the question banks. So I wanted to let you guys know about this point. All right, so how does a thrombus form that leads to a myocardial infarction? All right, so the first step is injury plus exposure. And by the way, this is primary hemostasis. I'm sure some of you are familiar from the gastrointestinal block hematology, the steps of hemostasis, primary hemostasis, secondary hemostasis. We're not going to be talking about secondary hemostasis, coagulation cascade. That's a headache for everyone, and I'm not going to be touching it. But I do want to touch on primary hemostasis, which is what's happening here. So the first step is when there's plaque disruption or an injury. This will expose the subendothelial collagen in the endothelium. And this will also be accompanied by transient vasoconstriction. So this is the first step. Okay, if the subendothelial collagen is exposed, the next step is von Willebrand factor is actually going to bind the exposed collagen. Okay, so once that happens, imagine von Willebrand factor now is binding to the exposed collagen. The platelet will bind the von Willebrand factor via glycoprotein 1b receptor. I'm sure some of you heard of that before, the GP1b receptor. What next? Step 3 is activation. Once the platelet binds von Willebrand factor, this will cause some conformational changes in the platelet, and it will cause it to degranulate and release 3 important substances. First one is thromboxane A2, which will activate nearby platelets. The second substance is ADP. It will bind to a receptor called PT-Y12 receptor, and this will cause the platelets to express the glycoprotein 2B3A receptor, which I also think you heard about before. The third substance is serotonin, which is a vasoconstrictor. Okay, important points here to note is that aspirin blocks thromboxane A2. That's why we use it as an anticoagulant. Also, I'm sure some of you heard of the drug clopidogrel or ticagrelor. Those drugs inhibit the P2Y12 receptor. That's released by ADP. Some of you heard it as ADP receptor blocker. That receptor is the P2Y12 receptor. So that's activation. What next? The fourth step is aggregation. From the activation step, we mentioned that the platelets are now expressing the glycoprotein 2B3A receptor. Why? Well, fibrinogen is going to bind the glycoprotein 2B3A receptor of 2 adjacent platelets, and it's going to link them together. And this repetitively will cause platelet aggregation. So the glycoprotein 2B3A receptor is important for platelet aggregation through fibrinogen. Okay? You can take your time to pause the video if you want to read over the steps again, just to hammer them down. But one more side point I want to mention, just very briefly, not that important, but just as a fun fact. You guys might have taken in hematology 2 diseases called Bernard-Soulier and Glasman thrombasthenia. Bernard-Soulier is when you have a deficiency of glycoprotein 1b receptor, and Glasman thrombasthenia is when you have deficiency of glycoprotein 2b3a receptor. So yeah, just wanted to throw that side fact out of the way. Anyways, let's move on to the next slide. Now that we know the pathogenesis of atherosclerosis, how it happens and how a thrombus forms, what about the risk factors? Who's at increased risk of developing atherosclerosis? At first glance, we all know that. Yeah, somebody who's diabetic, hypertension, smokers, all of that stuff. But it's important to know that diabetes is the worst out of all of them, but hypertension is the most common. You also have smoking, obviously, and cholesterol as well, either elevated LDL or a deficiency of HDL. These are all modifiable risk factors. The patient can modify their lifestyle to decrease those risk factors. However, there are also some non-modifiable risk factors, such as age, a male gender, and a family history. Now, I want to mention a few important points about family history here, and smoking as well. So, first of all, something you should really know is that smoking cessation is the single most important lifestyle modification, and it shows the most immediate effect. Now, I put it red for a reason because I really want you to know this, and you can assume why. So, smoking cessation, really, really important as a lifestyle modification. Next, family history. When do we consider family history positive in ACS? This depends on the age. First of all, when I say family history, I mean first degree relatives, parents, siblings, so on. The second thing I want you to know is the age. So the age of the first degree relative is less than 55 years old if they're a male, or less than 65 years old if they're females. Some sources vary with those numbers, but I got those numbers from Master of the Boards. So for example, if the patient's father died of a heart attack at the age of 69, this is not considered a positive family history. So I just wanted to clarify this point here. All right, so now let's go on to the approach to ACS. We have signs and symptoms first. There's something called the Diamond classification, and it identifies a patient's risk of CAD based on the following three symptoms. So I mentioned before that stable angina usually has substernal chest pain, that's worse with exertion, and it's relieved with nitroglycerin or rest. So those three symptoms are important. If you have three out of those three positive, then you have typical angina, which is definite. If you have two of those three, you have what's called atypical or probable angina. If zero or one of those three, then that's probably non-cardiac chest pain and you should investigate further. Okay, so this is commonly for stable angina, but what about unstable angina? Here's something to keep in mind, and one of the things I learned during when we took the lecture in third year, one of the things the doctor mentioned was that any angina of new onset, less than 3 months, is considered unstable. It will either progress to end-STEMI or stabilize to become stable angina. And in unstable angina, the pain is crescendo, as in it increases in severity, and it's not relieved by rest or nitroglycerin, as we mentioned from the spectrum table. There's also one more type of angina that I want to briefly touch on. It's called Prinzmetal angina. It's not really that important for the context of ACS, but I think just to give you the whole picture, I'm going to briefly touch over it. So Prinzmetal angina is when you basically have sudden vasospasms of the coronary arteries. There's no stenosis, there's no atherosclerosis, but the coronary arteries suddenly spasm or spontaneously contract like that. And this causes ischemia and chest pain. So this is called Prinzmetal angina. And the way you treat this condition is usually with calcium channel blockers. Why? Because this prevents calcium from entering the cell. And as you know, calcium is important in the cell contraction. And preventing calcium from entering the cell will also promote vasodilation. Side information about calcium channel blockers. A lot of us hear about the terms dihydropyridine and non-dihydropyridine calcium channel blockers. What does that mean? I sort of want to clarify this concept to you guys very briefly. When we say dihydropyridine and non-dihydropyridine calcium channel blockers, the way I want you to differentiate between them is on the location that they work. So dihydropyridine calcium channel blockers are going to work on the blood vessels predominantly, whereas non-dihydropyridine calcium channel blockers are going to work predominantly on the heart. So usually when you have a heart condition and you're giving calcium channel blockers, your choice would probably be non-DHP. How do you differentiate between them? Well, we know some common examples of calcium channel blockers are amlodipine, nifedipine, verapamil, and diltiazem. An easy way is the ones that end with idipine. Those are Those are dihydropyridine calcium channel blockers. Okay, so those ones are the ones that are going to work on the blood vessels. So amlodipine, nifedipine for the blood vessels. Verapamil, diltiazem on the heart. Another way to think of it, verapamil has a letter V. The heart has the ventricles, V with V. Non-DHP for the heart. Okay, so now that that's out of the way, we can move on now. So usually the classic description of someone presenting with acute coronary syndrome is going to be crushing retrosternal chest pain that will radiate down the arm and up the jaw. And some associations that can further hint towards myocardial ischemia is if the pain is accompanied by sweating, nausea, vomiting, or shortness of breath. Okay, so we talked about the signs and symptoms. What about the investigations? We have someone presenting with the signs and symptoms now coming to us in the ER. What do we do next? Well, the best initial test for any form of chest pain, ECG. And if you see ST elevations in an ECG, this will obviously indicate STEMI. But the way to think of a STEMI is a transmural myocardial infarction. What does that mean? It means that the entire wall is covered, as you can see here. The entire wall is affected, the entire wall of the heart. Whereas ST depression indicates a subendocardial myocardial infarction. So the area that I mentioned, the subendocardium, is this area here. It's the innermost or the inner third of the myocardial wall. Well, why? Because think about it. It's the innermost or the farthest away area. So it's going to be the most susceptible to ischemia. Okay? So this is when you have NSTEMI. It's really important to differentiate between the two. And moving on next. Keep in mind, as I mentioned before, that both unstable angina and NSTEMI have the same changes in the ECG. So you cannot differentiate between them just by an ECG in the ER. Next step, if you have an ECG with ST depression and you're still not sure which one of them it is, do cardiac enzymes or check the cardiac enzymes. If you have elevated cardiac enzymes, the diagnosis is most likely NSTEMI. So we know troponin and CKMB. Just very briefly, I want to mention which one of them is useful for diagnosing a reinfarction and why. The answer is CKMB, because if you see a patient, CKMB, because usually CKMB returns to normal levels after 2 days, whereas troponin stays elevated for up to 2 weeks. So if you see someone with elevated CKMB and then 6 or 7 days later they come with chest pain again and they also have elevated CKMB, you should suspect a reinfarction. Okay, so how do I know if someone had a previous infarct just from the ECG? You can look at the Q wave. And what does that mean? So this is the progression of the ECG findings after an ST elevation MI. I don't really know if you need to know all of these details, but what I want to hammer down here is weeks later or a long time after they have the MI, the Q wave is going to persist. You can see the Q wave here, which was not present here. So that's a good indicator that someone might have probably had a previous MI. I'm not really too concerned with all of these details here. I just want you to know that the Q wave is important. Okay, so we now mentioned that the ECG is the best initial test, but does that mean that is the most accurate test? No. One of the things you'll come across in third year is knowing what the best initial test is and what the most accurate test is. And it's really important to differentiate between the two. So the most accurate test to diagnose ACS is a coronary angiography. And obviously, although it is the most accurate, it's not efficient to use it as an initial test. It takes a long time, it's invasive, and it's just not an ideal choice to begin the investigations with. Okay, so now let's go on to the management of ACS. The management is divided into two things. One is revascularization, and two is concurrent treatment. And I'm going to explain what I mean by that in a little bit now. So revascularization is restoring the vascularity of the heart, obviously. And we can do that with two ways. One is the invasive procedures, either a PCI or a percutaneous coronary intervention. This is also known as an angioplasty with a stent, and I'm going to explain what that is in the next slide. Or we can do a CABG or CABG, as some people like to call it. It's a coronary artery bypass graft. The second option is thrombolytics, and I'm going to explain when is the ideal time to use them. The other thing is concurrent treatment, and this is with drugs. So Monabash is a great way to remember those drugs, and I'm going to go over them in the next slide. But like each letter stands for the name of the drug. And then dual antiplatelet therapy. for future management or for prevention. Okay, this picture here I think is very, very beautiful and important. I got it from Master of the Boards, and it has helped me a lot in understanding when to manage and what to give the patient depending on what they present with. So you have a patient coming to you with an ST elevation MI. The best thing to do is PCI. Obviously, the best initial thing, this is a common confusion point, is give them aspirin. Why wait for them to do the PCI if you can give them aspirin immediately and then send them for a PCI? You know what I mean? So ideally, the best thing is a PCI, but the best initial thing is aspirin. So PCI, usually, ideally, you want to give it in less than 90 minutes. Send them for a PCI immediately. The faster you do it, the better the prognosis is. Okay, in the case that PCI is not available, you can give them thrombolytics. Obviously, make sure they have no contraindications, such as a recent hemorrhage or any of that kind, because thrombolytics increase the risk of bleeding. But thrombolytics is used if you cannot perform a PCI. Now, for both NSTEMI unstable and ST elevation, you can give the drugs aspirin, clopidogrel, beta blocker, stat. Think of those as monobash in simple terms. Notice that in NSTEMI and unstable angina, you can also give low molecular weight heparin. So look at the unique things here. Thrombolytics are not used, thrombolytics are only used in ST elevation, whereas low molecular weight heparin is not used in ST elevation. So this is why this diagram is really good, because it helps you differentiate those small points. Okay, let's go into revascularization now. Percutaneous coronary intervention. It's the best therapy in ACS, should be done in less than 90 minutes, and it should not exceed 120 minutes. If PCI cannot be performed for any reason, and the patient has contraindications to thrombolytics, then you should perform the procedure as soon as practically possible. You don't want to wait until the patient dies. So how does it work? Well, basically you have a buildup in cholesterol here. The way it works is that you insert a stent with a balloon into the blocked artery. You're going to inflate it so you can dilate the vessels, and then you're going to remove the balloon, but the stent is kept here to hold the vessel open. So this is, in simple terms, how it works. Now, what about the complications of a stent? This is one of the points that I really didn't understand until recently, and I had trouble sort of comprehending what it meant, especially the term drug-eluting stents. Some of you might have heard it, some of you might have not, but I'm going to explain what that does. So the term drug-eluting stents, some stents are actually covered in a drug that prevents some of the complications. When I talk about the complications of a stent, I want you to think of two main complications. One is thrombosis, and two is restenosis. So this table summarizes those two complications. Let's talk about restenosis, because restenosis is the more common one of the two. Basically, when you insert the stent, there's a possibility that you have what's called a neointimal hyperplasia of smooth muscles in the coronary arteries, or hyperproliferation. Why is that? Sometimes restenosis is overgrowth of scar tissue. So sometimes when you insert the stent, you can have scar tissue that's going to overgrow itself, probably as an inflammatory response to the stent. I'm not 100% sure about that, but just a wild guess. But the main thing is there's a possibility of overgrowth of the scar tissue from the stent insertion. So you're going to have hyperproliferation of smooth muscles, and this can block the coronary artery again. So to tackle that, we can give two drugs. Actually, there's more than those two drugs, but those two drugs are just common examples: paclitaxel and sirolimus. Well, why those two drugs? What do they do? What are they? Very briefly, just as a side information for you to understand the whole picture. It's not really important that you memorize the mechanisms, but just to clarify it. Paclitaxel is a chemotherapy drug, and the way it works is that it hyperstabilizes the microtubule. You guys remember in the mitosis, there's one of the phases, I think it's metaphase. The microtubule is going to be, the chromosomes are going to be aligned in the middle. And then before they separate in anaphase, the drug paclitaxel sort of holds that microtubule position, and it's not going to let it break. Okay, so this will eventually lead to cell death, and I think this is why it's used in restenosis here, because it's going to prevent the proliferation of these smooth muscle cells by interfering with their microtubule function. So to put it in more context, in case I didn't explain it properly, I think a lot of you are familiar with with a drug called colchicine, which is used for gout. Colchicine is a microtubule inhibitor. It prevents the formation of the microtubule in the first place. So think of paclitaxel as the drug that works in an opposite mechanism. It allows the formation of the microtubule. However, it hyperstabilizes. It makes it so tight that it cannot break down, and this eventually will lead to cell death. So it works in a mechanism similar but opposite to colchicine. The next drug is sirolimus, and it's an immunosuppressant that's commonly used in kidney transplants. So notice that both of these drugs prevent the proliferation of cells, which makes sense why they're used here. The second complication that can happen is thrombosis, and this can be prevented with the antiplatelet therapy, which we'll discuss further on, the dual antiplatelet therapy. The second revascularization procedure is CABG, and I'm not going to talk a lot about it because it's not really important, because it's not routinely recommended. In case PCI was unsuccessful, or if there was significant stenosis of like 3 vessels, or the left main coronary artery, or 2 vessels in a patient with diabetes, those severe cases are when CABG could be an option. But like I said, it's way more important to understand PCI rather than CABG or cabbage, whatever. So let's move on to the concurrent treatment, the drugs. We have Monobash. It stands for morphine, oxygen, nitrates, aspirin, beta blockers, ACE inhibitors, statins, and heparin. So nitrates are given for symptomatic relief, and they are contraindicated in an inferior wall myocardial infarction. Why? I'm going to explain that in a little bit. Aspirin, as I mentioned, it's the best initial. Immediately give them aspirin as soon as you can. So beta blockers have been proven to decrease long-term mortality. It's contraindicated in heart failure. However, when you study heart failure, you're actually going to realize that beta blockers is one of the drugs that's given in heart failure. A long time ago, it was common that beta blockers were contraindicated in heart failure. I'm going to explain why in a little bit. However, evidence has shown that they decrease long-term mortality. So you need to be very careful when you use beta blockers in heart failure. So you need to know if it's decompensated or compensated, whether it's risky enough to give beta blockers, whether the risks outweigh the benefits. All of these details, I think you're going to come across them in the heart failure, so I'm not going to go too deep into that. Next, we have ACE inhibitors, statins, high intensity, of course, and heparin. Low molecular weight heparin is preferred here. It's has less side effects, requires less frequent monitoring, less incidence of heparin-induced thrombocytopenia, so on. The next thing I want to touch on is the dual antiplatelet therapy. So all acute cases should receive dual antiplatelet therapy if PCI was performed. And I mentioned that this prevents the thrombosis complication of PCI. So usually the dual antiplatelet therapy is aspirin plus a P2Y12 inhibitor, clopidogrel, if you recall from the ADP part of the primary hemostasis. Now, after 1 year, you're going to check the bleeding risk. Obviously, since they're anticoagulants, they have a risk of bleeding. So for example, a patient who has a peptic ulcer, you would probably need to really consider if they should receive dual antiplatelet or not. Anyways, so after 1 year, you check if they have a high risk of bleeding, you switch them to a single antiplatelet therapy. If they're not at high risk of bleeding, continue the dual antiplatelet therapy for up to 3 years. Okay? Now, let's go on to angina management. I think a lot of us are familiar with the nitrates and beta blockers being used in angina, but the thing that really confused me at the time, and only recently did I understand, is what's the difference between the two in terms of how they work, and why are they combined with each other? So this table really summarizes these points here. Now, what I want you to understand is this part here, the end diastolic volume. What is the end diastolic volume? In short terms, it's the preload. It's the amount of blood that's returning from the systemic circulation to the heart. So preload. Nitrates decrease preload, whereas beta blockers can either keep preload normal or increase it. Well, why? a good way to think about this is that nitrates are going to dilate the venous vessels. So it's a venodilator. And when you dilate the venous vessels, this will promote the pooling of blood in the systemic circulation. This means that less blood is going to leave the systemic circulation to return to the heart. So there's going to be less blood returning to the heart, and this will lead to decreased preload. And if you have less blood returning to the heart, this is going to lead to a decreased blood pressure. Now, why are contractility and heart rate opposites in beta blockers and nitrates? Well, if you have low preload and the blood is receiving less blood, it's gonna have a reflex response to increase its contractility and heart rate to keep up with the demand. And speaking of demand, sorry, I forgot to mention this, but the main goal here, since we mentioned before that it's stable angina is demand ischemia, we want to reduce the myocardial O2 consumption as much as possible. So that's why decreasing the preload in this context is a positive thing. If the blood is receiving, if the heart is receiving less blood, it's going to have a reflex response of increasing the contractility and the heart rate. So this is why when you give nitrates, you're going to have increased contractility and heart rate. Well, what about beta blockers? Well, beta blockers do not dilate the venous blood vessels as much as nitrates do. So the way to think about it, as you know, the heart has beta-1 receptors and the blood vessels have beta-2 receptors. Think of beta blockers working in terms of the location. So if I block the beta-1 receptors in the heart, I'm going to decrease the contractility and I'm going to decrease the heart rate because I'm blocking the beta receptor. This is why it's opposite to nitrates here. Well, what about the preload? Well, the way I like to think of it, and I'm not 100% sure if it's truly accurate or not, but the way that I understood this is that beta-2 receptors normally in the blood vessels, they dilate it. So if you block that receptor, the beta-2 receptor in the blood vessel, you're not going to dilate them, so you're going to constrict them. And as I mentioned, if vasodilation in the veins caused by nitrates decreases the preload, then constricting those vessels is going to do the opposite. So that's why you have increased preload here. And notice how some of them have opposite effects, but if you combine them together, they're going to cancel out. So that's why, ideally, it's a good thing to combine nitrates and beta blockers in angina. I really wanted to highlight those differences here because it really took me a very, very long time to understand why we use nitrates and beta blockers and why we combine them. And let's go back here to when I said nitrates are contraindicated in inferior wall MI. Recall that nitrates are going to decrease the preload. So if you have an inferior wall MI, which indicates an infarction in the RCA, if you recall, so on the right side of the heart or the inferior surface, the right side of the heart is preload dependent, meaning that it depends on the amount of blood that's returning to it. So if you already have an inferior wall myocardial infarction, ischemia on the right side of the heart, and you decrease the preload even more with nitrates, then that's gonna cause even more problems. So I think that's why it's contraindicated here. And I really thought it would be useful to explain those differences so you can understand that point and also understand why we use those drugs for angina. Okay, so let's move on to the next slide. Let's look at some scenarios now that we have a good understanding of the approach. You have a patient coming to you to the ER with crushing chest pain. You performed an ECG and you saw ST segment elevation, myocardial infarction. What is the best next step in management? You can pause the video to take a few seconds to think about it, but I'll pause for like 2 seconds. So the best management here is to give them aspirin. Some people might choose PCI, but as I mentioned before, why wait for a PCI when you can give them immediately aspirin and then send them for a PCI? It literally takes seconds, yani. But after aspirin, then you do a PCI. So another scenario here. A patient comes to the ER with ST segment depression. Aspirin and clopidogrel have already been given. What is the best next step in management? So the answer is giving low molecular weight heparin. Why? Recall the algorithm I showed you here. And I told you that in cases of NSTEMI and unstable angina, you can give the patient low molecular weight heparin and then send them for an early PCI. Okay, so I want you to keep in mind that thrombolytics are only given for ST segment elevation, and low molecular weight heparin drugs are not used in STEMI. And this is outlined here. Okay, so let's talk about the complications now. Specifically, I want to talk about the complications of being myocardial infarction type 1. Wait, what? Type 1, you mean there's a type 2? Sadly, yes, there's a type 2. Not only that, there's 5 types of myocardial infarction, and the type 4 is subclassified into 4A, 4B, and 4C. So pretty overwhelming, huh? Well, you don't have to worry about any of that. We're only going to be talking about type 1 here. So when I heard about this, when I was taking the lecture, I kind of freaked out. Like all my life, I knew of myocardial infarction as myocardial infarction, didn't know it had types. And all of a sudden, you're telling me there's 5 types. So set that aside. Don't worry about that. All I need you to know is the stuff related to type 1. This page beautifully outlines the complications and the timeline that happens in MI. So to understand the complications, it's really good that you first understand the sequence of events that happen. So very briefly, you can pause the video if you want to read the page on your own, but I'm going to highlight the important things in this page. So 0 to 4 hours, everything is going to be pretty much normal. You're not going to see any changes, not grossly, not histologically, okay? You start seeing the changes of coagulative necrosis right around 4 hours later. So on the first day, you're going to have early coagulative necrosis. And you can also have reperfusion injury. What is reperfusion injury? Basically, think of it as restoration of blood flow to an ischemic area. If you restore blood flow to an ischemic area, this will cause calcium to accumulate intracellularly. And we know that calcium is a potent activator of enzymes. Plus, it leads to contraction inside the cardiac muscle cells. So you're going to have hypercontraction of the myofibrils, which can be seen histologically as dark eosinophilic stripes. But the main thing I want you to know is that early coagulative necrosis is seen in the first day. The second day, I'm going to touch on the complications later. For now, I just want to go through the changes. The second to third day, so 1 to 3 days, you're going to see acute inflammation. The coagulative necrosis is going to be extensive. You're going to have acute inflammation with neutrophils. Next, from 3 to 14 days, so 1 to 2 weeks, you're going to have macrophages predominate. And you're also going to have the formation of granulation tissue. After that, 2 weeks up to several months later, you're going to have the formation of a scar, which grossly here appear as gray. Okay? So keep in mind that when the scar is stabilized and formed, it's mainly composed of type 1 collagen. You guys aren't going to take in the surgery lecture, in the wound healing lecture, the type 3 collagen and the type 1 collagen ratios and how those are implicated in wound healing. But keep in mind that eventually type 3 collagen in wound healing is going to be replaced by type 1 collagen. Okay, so what about the complications now? The most feared complication is ventricular fibrillation. And it's the most common one, actually, I think. I think arrhythmia is the most common complication, but don't take my word, I'm not entirely sure. You can double check it. But what I want you to know is that it commonly happens during the first day. Arrhythmia, on the first day, we're worried about arrhythmia, also heart failure and shock. In 1 to 3 days, we're worried about what's called post-infarction fibrinous pericarditis. So how do we know if a patient has pericarditis? The main clues to identify pericarditis is sharp pleuritic pain. That means whenever they breathe, they're gonna feel the pain even worse. It's gonna get worse when they lie down flat, and it's gonna be better when they lean forward. So this hints towards pericarditis. On auscultation, you're gonna hear a friction rub because of the pericardial inflammation. So if you see a pericardial rub on auscultation in a patient that recently had a myocardial infarction, this could be one of the complications of the MI. Okay, now there's a lot of words here, and it might seem confusing, but I'm going to explain it in very simple ways. hopefully that you guys will understand it by common sense and not by memorization. So a free wall rupture, why does that lead to cardiac tamponade? Think of it as if the wall of the heart ruptured, blood is going to be able to leak into the pericardial space. And you guys know that tamponade, cardiac tamponade, is fluid accumulation in the pericardial space. So this is why if the free wall ruptures, blood is going to be able to leak out into the pericardial space. Common sense. You can figure it out without memorizing it. What about papillary muscle rupture? Why does that lead to mitral regurgitation? Well, think of it as the papillary muscles are the ones that are holding the valve. So if you have rupture of those muscles, the valve is not going to be stabilized properly. So there's going to be leakage of blood through the valve. So that's why it causes mitral regurgitation. Okay. What about interventricular septal rupture? Well, think of the interventricular septum as the wall between the right ventricle and the left ventricle. Imagine that ruptured. Since the left ventricle has extremely high pressure in comparison to the right ventricle, and the wall between them is open, due to the pressure gradient, the blood is going to leak from the left side of the heart to the right side of the heart, going from high pressure to low pressure. So this will create what's called a left to right cardiac shunt. And you can see the same thing happen with a ventricular septal defect. So if you have a defect in the interventricular septum, the blood is going to go from the left side to the right side. Pseudoaneurysm, I'm not going to really talk about it that much because I don't want to spend much time on something that's not that important here. So the last thing I want to touch on is Dressler syndrome. Dressler syndrome, think of it in very simple terms as autoimmune pericarditis. So same symptoms as I mentioned before in the fibrinous pericarditis, pleuritic chest pain, relieved by leaning forward. So how do we differentiate between the two? Well, the timeline. If you see the symptoms happen just a few days after an MI, think of post-infarction fibrinous pericarditis. If it happens weeks later, then you think of Dressler syndrome. So this table has the complications, most of which we already talked about, so it's nothing new here. But if you want, you can pause the video to read through it and understand how they all tie together. Cardiac arrhythmia within the first few days, it's the most important cause of death. I think what I meant to say before is that it's the most common cause of death, not the most common complication. So these are all the complications we talked about: fibrinous pericarditis, friction rub, papillary muscle rupture, mitral regurgitation. Notice here that it says posterior medial papillary muscle rupture, increased risk due to single blood supply from the PDA. So this ties back to the anatomy that I explained earlier. You can go back to it if you want. Then we have the interventricular septal rupture. As we mentioned, it can cause a ventricular septal defect. And yeah, I think you can just read through the rest. So we're pretty much done here. Just a few things that I want to mention here. So this is some extra helpful information to differentiate other causes of chest pain from ACS. So if you see somebody coming in with chest pain and they have chest wall tenderness, think of costochondritis, and you would easily identify it with a physical exam. If the patient has sudden onset tearing pain radiating to the back with unequal blood pressure between the arms, think of aortic dissection. And as I mentioned, pain worse when lying flat, better when sitting up, pleuritic, that's going to be pericarditis. So epigastric discomfort, pain relieved after a meal, think of a duodenal ulcer. If the patient has bad taste, hoarseness, or coughing with a chest pain, think of gastrointestinal reflux disease. Sudden onset shortness of breath, tachycardia, and hypoxia, think of a pulmonary embolism. And remember, one of the things that can hint further towards a pulmonary embolism is Virchow's triad. You guys are going to take it in surgery, which is blood stasis, hypercoagulability, and endothelial injury. So some common clues for pulmonary embolism usually is a pregnant woman because of hypercoagulability, a patient who just came back from a business trip traveling on an airplane. There's a period of stasis because they're sitting on the airplane. So all of these are helpful clues to differentiate the causes of chest pain. And if you have sharp pleuritic chest pain, but they describe that there's a tracheal deviation on X-ray, here you wouldn't think of pericarditis, but think of pneumothorax, okay? So very brief summary. In stable angina, the pain is relieved by rest or nitroglycerin. If the pain is unrelieved by rest and you have ST depression or T-wave inversion and normal cardiac enzymes, that's unstable angina. If it's the same as the above, but the cardiac enzymes are elevated, that's NSTEMI. If the ST segment is elevated, and the cardiac enzymes are elevated as well, that's STEMI. For the investigations of ACS, best initial is ECG, most accurate is coronary angiography. For the medications, we mentioned Monabash and thrombolytics for STEMI if PCI is unavailable, or low molecular weight heparin for NSTEMI and unstable angina. And for the management, best initial is aspirin, but keep in mind that you want to do a PCI as soon as possible. So always remember this figure from Master of the Boards. It's been really helpful to me. So thank you guys for listening. I know it took a very long time, but I really wanted to highlight the mechanisms and sort of explain things to you in a way that you understand them instead of memorize them. So hopefully that when you go into the lecture, you already have a very good idea of what's going on. If you have any questions, you can feel free to contact me. My Twitter username is here. For anyone interested, I also made a summary of the cardiac cycle or the cardiac chapter in Master of the Boards. Plus, I have an ECG course summary. I went to an ECG course once, paid a bunch of money for it, but I eventually summarized everything. So to spare you from going to an ECG course, you can contact me if you want a copy of that summary as well. So this is it. I hope it was useful. And yeah, good luck to you all. Thank you.